West Palm Beach, you're on Newsmakers.
Yes, my question has one of two parts. I just had a baby. My breasts were small before I had the baby, and after I breastfed, I mean, they were small and droopy, so I can like emphasize with the woman that you had on before. Really, it's really something else because society, you know, I do want to get an implant, okay? Because I feel my husband doesn't like it. I want more, you know, cleavage. Can you understand that?
I understand perfectly well, and the only thing that I can tell you is that I can empathize with your frustration. I really think that there is a degree of illness in our society in this area as there is with others. We really have taken breasts and magnified them with the marketing that we've done, with the clothing that we've done. We really have made a very difficult position for females in our particular society with our mores and cultures to get them to fit into what we as the public decide as the appropriateness of your body habitus and structure. And it is a very frustrating position, I am sure, for ladies to be in. Again, I can only empathize with you and understand what you're saying. What I would suggest, though, is if you have had a baby, that you should wait approximately 6 months to a year before you decide to have the implant. There is no harm in having the implant done, but the fact is that the breast physiology and anatomy changes with pregnancy, so that the safest thing to do is to let those changes go the natural way and have the changes pretty much done before you think about having the implant put in.
Did you have another part to the question, or was that it?
Yes. What about self-examination during, I mean, like when you have an implant? Okay, what about, you know, like once a month and you want to examine yourself? I mean, does that interfere with feeling, you know, being as though you have that silicone bag in there? Can you feel like other changes?
All right, let's let Dr. Barr answer.
I think that your point is very well taken. First off, I would think that people that have had breast surgery are going to be much more prone to do self-examination because they're much more aware. And I think particularly after they go through the process of selection and dealing with the plastic surgeon and all the things that are involved with the surgery itself, it really tunes them in. Again, anatomically, where we were putting the implant is behind either the gland or behind the muscle which lies behind the gland. So in reality, the gland is sitting on top of the implant. So as far as interfering with things of that nature, it should not. Now, if you develop a problem with a scar capsule or hardening of the breast, then we're talking different elements, and that's one of the problems with the implants themselves that we are trying to address with the textured implants and other things of that nature to help out with that problem.
Thank you for your call. Boca Raton, you're on Newsmakers.
Yeah, good evening.
Good evening.
I've had rhinoplasty, well, actually reconstructive surgery on my nose twice over the past 2 years because of a traumatic problem that happened when I was about 12 years old. The lateral cartilages collapsed and whatever. I was told by my surgeon that I was going to probably need some extensive surgery, possibly 2 or 3 surgeries. My question to you is, I've had 2 surgeries already. The problems that I went to the surgeon for initially have not been taken care of. How many times can you have surgery done on a certain area of the body without having it fall apart or not having enough pieces to work with? They've already removed a lot of cartilage from my ear to put into my nose because the cartilage in my nose was gone.
Again, a very good question, and I think the concept that you have is correct, except that what I have found is that it's not necessarily the pieces falling apart, but a tremendous amount of scar tissue that may build up after repetitive procedures. And one of the things that we take as a basic principle for this practice is that we should not do surgeries until the scar tissue that has formed from one set of surgeries has not necessarily diminished, but we call it maturing, where that scar tissue will become as soft and as moldable as it will be. But the real problem that we find is that as we violate the tissues more with surgery, we are producing the scar tissue, which is a inelastic, non-yielding replacement for the normal tissues that were there before. And those will be the things that may cause the problems with not being able to allow the expanse or space to put the cartilage back into, or cause the problems of the constriction and the binding down that makes what you are saying a very difficult problem.
Thank you for your call. I'm going to ask the other callers to just be patient and hold for a minute because I want to get back to the slides. However, for those of you who are just joining us, we are talking about cosmetic plastic surgery, and some of the pictures that you're about to see can be considered graphic, so I just want to forewarn you. We've been talking about really elective type surgery, people who wanted to enhance their beauty, but plastic surgery is also for those who have a disfigurement. We're going to take a look at someone who has a cleft palate, a baby who was born with a cleft palate, and what can be done with plastic surgery. So let's take a look at the first slide.
This is what we would call an incomplete cleft lip. The reason that it is cleft is because the formation or the juncture of the two sides of the face have failed to adequately come together here. But if we look at it closely, one of the wonderful things that we've discovered, the past professors and hopefully future ones, have seen that all of the elements are there, but they are malpositioned. So the beauty of the surgery that is being done today is taking these parts and repositioning them to give what hopefully is a better appearance, not only from a standpoint of appearance, but we are actually taking the muscle that is across the lip and joining that as well. So we are getting both function and cosmesis.
And let's take a look at the child after surgery. Do we have that slide? No, we're having trouble finding that. All right, well, we're going to go back to the phone line then for a minute until they can come up with that slide. So, all right, we have the slide. Okay, let's take a look at...
This is showing the markings in surgery, and this type of procedure that is being performed here has been very much written about and really perfected by a professor from Miami by the name of Dr. Millard, who is an excellent physician, surgeon, and this is the procedure that I use and many other surgeons use today. It is reliable, it's standard, and by using that type of surgery, hopefully we'll get the next slide now, which will show. This is, yes, that's it. No, go back. This is what we would consider a usual, typical result of doing this type of surgery. There is a scar, but we have minimized both the functional component and the cosmetic component into something, hopefully, that that child will be able to live with, and the parents.
Now, the next slide we have is, this is considered a cleft palate?
This is a combination both of both a cleft lip, which was more severe. This is a complete cleft lip, and also the palate, or the lining between the oral cavity or the mouth and the nose, is absent.
Which we can see in the next slide. I think
Right.
we have a shot of the interior of the mouth, and you can see where the upper palate is.
This is the palate, and what you're seeing, you see the blue, which are the markings for the surgery that we will use to bring the two halves together in the midline. In the midline, what you're seeing is really looking into the nose, because the tissue is not there. That is the cleft of the palate. And the next slide should show, there is after the surgery has been performed. And again, something else to draw your attention to is that there also is a nasal deformity with the cleft lip and palate patients. And that is something else that is addressed, as well as a prolapse or an indenting of the midface. These are multiple different areas that are involved in multiple stage surgeries, and as part of a team, because usually we are working with not only the surgeon, but as with the speech therapist and the orthodontist and the dentist, and there are a number of people that are involved that make this process successful. And I can't stress that highly, that most of these procedures are team approach.